Πριν αρχίσουμε την πολύ σύντομη συζήτηση που πρέπει να γίνει, γιατί καθυστερούμε, έχουμε δύο, νομίζω, απαραίτητες παρεμβάσεις. Ο καθηγητής, ο κύριος Κόκκινος, θα μας κάνει μια παρέμβαση. Είμαστε πολύ χαρούμενοι που τον έχουμε εδώ, όπως πάντα, κύριε καθηγητά. Και ο κύριος Αθανασόπουλος θα ακολουθήσει διαδικτυακά μια πολύ μικρή παρέμβαση.
Yeah, and seems that let's switch to English because we get some messages in the chat. People are online and they're asking for English.
Okay. And also, Elliot Smith is here. Thank you, Elliot.
Okay.
Yeah, it's okay.
Thank you, Professor.
I'll do that. Professor Dangas, I'll speak in English. Okay. Dear John Yakovou, dear Themis Hamogiorgakis, dear friends, thank you for inviting me here, taking me back from my retirement. And I would just like to give a few thoughts because it's not all mechanical. We're speaking up to now mechanical. One thing that Dr. Pereas corrected me, I was ready to say that in a center like ours, with a very big number of both surgical and interventional results, we don't have enough registries. It's a pity. We should have. I was discussing with my old friend, Professor Kremastinos, with whom we were friendly rivals, the two clinics, for 15 years. And about equal, we were publishing about 30 papers per year, each department at that time. And we said once, I told him, Dimitri, one thing we didn't do. We didn't do registries. We tried to do studies in vitro, in vivo, but no registries. A center like ours should have registries. So this is a thought from an old timer. I would say the following. A recent paper, very recent paper, 25, is speaking about this, tackling the in-stent restenosis. Now, in the eluting stent area. Don't forget that it is 10% still now, and with diabetes mellitus it is 20%. If we could improve this, then we could have equal results in the two techniques, and I will not go in the dispute. I love both of them, and I've followed both of them, so really I'm not a fan of either. I think they are both good. But the 10 and 20% is a big number. In this paper, they had a lot of reasons. But look at the red. They had no mention of molecular processes. And medicine and cardiology is now molecular. A few years ago, Renou Virmani was following the histologic approach. This is fine, but now it's molecular. So we are not talking, I didn't hear one word about inflammation, proliferation, apoptosis, ferroptosis, piezosensitive. I will say what is piezosensitive. So nothing basic. Don't forget that turbulent flow, and your teacher, John Colombo, Professor Colombo, first said that if you expand the stent well, you don't need anticoagulation.
Yes.
Because the flow was not turbulent, it was linear flow with a better stent. And turbulent flow induces mechanotransduction, induces abnormal hemodynamic of the stent area. And from the endothelium, you get epithelial mechanical mesenchymal transduction, which is the cause of all evils. Once you don't have real endothelium, you have thrombosis, you have inflammation, and activation of the smooth muscle cells, proliferation. And I have been working recently on ferroptosis. It's a new form, 12 years old, not new, but still, it's a juvenile. it is found in in-stent restenosis. And it's funny that clopidogrel decreases ferroptosis while aspirin increases ferroptosis. And a very recent paper in Chicago, 2 weeks ago, found by Choi et al., found that post-NTMI, late after, clopidogrel decreased it at 3 years, while aspirin increased it. So it may be time to reconsider if we should stay on aspirin or use clopidogrel above other things, above strokes and other things. And a new drug, which happened because the researchers could reposition the drug, the SGLT2 inhibitors, which started as a diabetic drug and it is now against heart failure, also may improve in-stent restenosis. So all our patients could need SGLT2 inhibitors. And many of our patients who are diabetics, if the 20% could become 5%, it's a big improvement. The other great family, GLP-1 agonists, no effect on that. Clopidogrel found, as I said, fewer acute stent administrations aspirin, and SGLT2 inhibitors have been found to improve restenosis and also increase the intracoronary microvasculature. And we all know that a good microvasculature distal to the stent is very important to improve restenosis. And very, very recently also, they found that it was better after TAVI. So my message today is, of course, we're improving the mechanics all the time, but we should also look at mechanisms, which are very important. You don't have all improvements in stents, in wires, in impellers, but a huge improvement in drug therapy, which we should not forget. And thank you very much for inviting me in this very nice lecture, to see old friends, to see George Dangas, to see my very good friend from Belgrade, Goran. It's a pleasure. You know, Goran found while he was here the flow index, and it's still going strong and stronger.
Exactly. This is a primary QFR. So
yes.
So he did the most with very
he was
low
here with us
technology at that time. So this is
and he has become a good friend of the hospital as well. Thank you very much.
Great. Dr. Frangoulis is going to give us his comment now, so we can move on with the discussion, and right after the chief surgeon here, Kamouliarakis.
And also Dr. Balanika and Dr. Athanasopoulos as well has a small comment. Socrates, and then,
yes, I would like to say a few words about the cases that you presented before, Dr. Tsiafoutis. As a surgeon, I would like to know that some of your patients we will operate it here, and I have a question about your complex cases. How much time do you need for a complex case in media?
It depends. Depends on if you use LV support.
1 hour, let's say.
Yeah. It's 2 or 3 hours. Something like that. All the procedure.
1 hour all the procedure?
No, 2 or 3 hours.
2 or 3 hours?
Yeah.
I have
from the beginning to
I have a
the
comment.
device.
We need 35 minutes for three anastomosis.
Yeah.
But only for the surgical part. Before and after, putting the drapes, how long does it take?
2 hours skin to skin.
Okay, so it's 3 hours.
I'm talking from the beginning to the end. A patient outside the cath lab to go to his bed. But we have complex cases that they can fix it in 1 hour. It depends on the patient. It's not all the same.
And sorry, George, the idea is to have complete revascularization, right? and in
I'm
a
talking
most
for
appropriate
complete-
way. So, you know, we saw these 3 columns that Professor Kokkinos showed. But I think, of course, molecular mechanisms, we don't know exactly. Maybe we don't have randomized data, and but this is very important to know and to be aware of. But for us, interventional cardiology, the most important thing is to properly expand the stent. So this is the biggest factor of stent expansion, stent thrombosis. So if you, the full metal jacket might be, you know, might be a solution from time to time, but it's not the proper solution, because as we learn from you, it's you know, you destroy the Wind-Kessel effect. You don't have elasticity of the vessel, and maybe it's better in some of the situations to have a patient operated.
No, that's okay for me.
Dr. Hamogiorgakis,
Thank you.
Themis.
In my opinion, it should not be a matter of debate. All those cases should be approached as a heart team, and those cases that there are good surgical candidates, I mean, there are clear indications who should go for surgery and who should not. And for those cases that there are high-risk surgical cases, and we turn them down as surgeons, I mean, there's only one way to go with a PCI. So I think it's clear in my mind, and it should not be, you know, a matter of debate. Now, the other thing that I would like to point out, as you mentioned, that you do high-risk PCI with support. Sometimes Impella is not enough, and you may have to be ready to place somebody on ECMO. So you have to be really, depending on the patient's oxygenation, the patient on pulmonary edema, et cetera, how the right ventricle is performing throughout the procedure. So you should be ready for that option also.
Well, that's another hybrid procedure, right? It's a very big surgical procedure, sometimes to do the ECMO and all that. Let me just make one comment that, because we heard a lot of registries, trials, opinions, I just want to make a general comment that it's not everybody who goes in the trials. The trials are good because it's randomized, of course. And the trial is about the strategy. So it's not like you're randomized to go to surgery, you never get PCI. You may get PCI later down. There's a problem with the bypasses. If you get surgery first, you may get PCI later. And if you get PCI first, you may get surgery later. But most importantly, as we all know, it's very difficult to put a patient in the trial. The trial patients they need to want to be in the trial. So it's not everybody, it's not mandatory. You cannot tell people, oh, today in the cath lab in Entaro Nasio, we don't do anything. You have to go through the randomization. If you really want to have a generalizable trial, you have to go to these draconian methods, but that's not ethical. So the people in the study, they have to think who was not in the study. And who was always not in the study is most of our patients that say, I don't want anything maybe. Maybe I want a PCI, or maybe, I don't know, I want a bypass. There are patients, the majority of the patients do something different other than the trial. So that's why it's not an edict, the trial. It's just a guidance. And the guidance, we have to take it to the heart team with the patient's cardiologist, clinical cardiologists, I mean, in the community, not even here, where they belong, where they're going to have the secondary prevention. Because in the end of the day, as Professor Kokkinos indicated, the well-being is not going to be about, I took an hour in the cath lab or 2 hours in the surgery. No, it's going to be, did you decrease the inflammation? Did you decrease the insulin resistance? Did you optimize the lipids? Did you stop the smoking? That's what's going to give the long-term effect that we both want. If you do none of that, you're going to have PCI after bypass, you have bypass after PCI, because everything is going to keep closing up. Don't forget about that ever. And one more comment, I think Dr.
Yes.
Balanika would like
Dr.
to make
Balanika,
a
you want to
brief comment?
She's a co-moderator.
If you like.
So it's the...
In this case, the role of the anesthesiologist is to contribute to the outcome optimization, because all these patients are high risk, and we have to ensure the hemodynamic stability. They have low ejection fraction, so we have to contribute with the monitoring and the use of the appropriate inotropes to optimize the stability and to prevent severe complications like acute kidney injury, which is a main risk factor contributing to the high mortality of these cases.
Excellent. Any comments from the discussions? Dr. Avgerinos, Dr. Chryssopoulos, Dr. Anakides, yes.
To my surprise, there has been no mentioning in the hybrid approach, in the combination of treatment for those difficult cases. And I would like to ask from the speakers if there is any data, because in many countries, like in Germany and in Canada, the hybrid technique is the first option of treatment of those cases.
If I may, I really believe in it, partly because we've got the new hybrid room, so we've got to try and use it effectively. I'm sure there's data that's missing. I didn't have enough time to show you all this. What I was referring to is we don't know whether a lima in a minimally invasive way plus a stent on the mid-RCA is a better procedure than doing everything one or the other way. But the other real life, and we know this, is because of logistics, maybe in Onassis we have an advantage. The uptake rate of hybrid procedure is less than 1% worldwide. You know this. Yeah. So it's been discussed for the last 5-6 years, but there has not been an embracing from the cardiological and cardiothoracic world. Maybe because we're still, and this is the only comment I would like to add, because what Professor Danka said is very accurate. I did try to show registries too. The uptake of trials is less than 10%, so it's not showing the real world. But the important thing is that we keep discussing. And I think our failure in many parts of the world is that we decide based on our perceived risk. Like Themi said, we have high-risk cases, but we want to listen to you and learn which is a high-risk case from your point of view, so we find the least dangerous procedure for each patient, other than deciding on ourselves, each community. So I think this is a great opportunity to realize that we can do this hybrid, for example, as John is saying, but we need to discuss logistics of antiplatelet therapy, duration, and all this stuff, which need a lot of thought.
George? Well, I mean, the hybrid is a good idea. It's a Greek word, huh? It's a good idea. But we haven't figured out how to do it. And perhaps we may not need to figure out how to do it. The simplest way to do the hybrid is to do a stage. The only reason to try to make things complicated on the same time is because there is an operating room called hybrid. But what's the reason exactly? We all know from many studies, even if you have 80–90% lesions, they can wait. The one thing we learned from the studies is that, sure, maybe ultimately you do PCI, this and that, but there's no penalty for waiting 1 to 3 months. No penalty. So if there's no penalty, why do we have to do everything today? We can do some stents today, and they can do a lima to LAD in a month or two, or vice versa. They can do a lima to LAD, and somehow things don't work very well, or they don't like the aorta, they can close up and say, you know what, I tried to do triple bypass, things were looking good, but somehow they didn't really look good in there. I'll just put a lima to LAD, in a couple of months, go ahead. Those procedures are many, and they're not captured, because the less than 1% is this combined situations that there we have a problem with pharmacological therapy. You have to open the chest, put the stents, put on Plavix, they have the chest tubes, how do you do all those things? I think we're making things more complex than they need to be. And I do think that is more than 10%, this type of staging that I told you, it's just difficult to capture it, because, you know, it captures as a bypass, and a month later there's a stent, and, you know, that's kind of lost unless you're specifically looking for it.
May I ask Elliot Smith, Elliot, are you aware of any group in the UK that consistently does hybrid procedures, PCI and CABG?
No, I don't think there's groups that consistent. I don't think there's groups that do consistent hybrid approaches. Hi everyone, I'm Elliot Smith, I'm from London, so thanks very much for the invite to join your conference. I think the issue tends to be trust and over-promising. So it's exactly what you were saying, that there's a sort of conflict between what one group can do and what the other group can do. Actually, if you relax a little bit more about it and everyone's honest, then the interventionist can say, we can treat that really well, but I can't deal with this lesion particularly well. If there's a fantastic target for the LAD, but the other areas really do not look amenable to being grafted, sometimes what we get is that they go for surgery and those areas never get grafted because they were, inverted commas, too small. And then they go through the system for months and months and years with ongoing angina, and we never get to them. So I think the heart team is the gateway. I think that in the highest risk cases, often, if we can do it percutaneously, that's great. In the lower risk cases, it's going to be very difficult to prove that if you take the prognosis with a great lemur, that we would make a huge fundamental difference on the other two vessels that could be grafted at the same time.
Good, excellent. Thank you, Elliot. So we have to proceed to the next table, but Dr. Athanasopoulos has a comment.
Let's connect online because I somehow, Dr. Athanasopoulos not here.
Yes.
Καλή σας μέρα αγαπητοί συνάδελφοι. Λυπάμαι που είμαι εκ του μακρόθεν για οικογενειακούς λόγους. Αποτελεί ιδιαίτερη τιμή και χαρά να αναφερθώ στην εκδήλωση για τη σύγχρονη υπερβατική διαχείριση στεφανίας νόσου, στεφανίου συνδρόμου, όπως πλέον από το 19 έχει μετονομαστεί. Αυτή η εξωστρεφής πρωτοβουλία του κ. Ιακώβου θεμελιώνεται έγκριτα με την εξαίρετη συγκρότηση του τρέχοντος προγράμματος. Σύμπλοκες στεφανίες βλάβες, βλάβες τελέχους, διχασμών, χρόνων αποφράξεων, οι παρεμβάσεις συνδυασμένης αιμοδυναμικής υποστήριξης, όπως ήδη ανέλησε ο κ. Τσιαφούτης, αποτελούν διακριτές συνιστώσεις της επεμβατικής καρδιολογίας, εμπροκειμένου πάντοτε σε διαλεκτική σύνθεση με τη χειρουργική πρακτική, όπως διεξήλθε ο αγαπητός κ. Περέας. Η αξιολόγηση στεφανίας φυσιολογίας παράλληλα με την εξελιγμένη στεφανία απεικόνηση καθίστανται όλο και περισσότερο αναγκαίες στην ορθολογική επεμβατική διαχείριση. Οι ουσιαστικές ωστόσο αλλαγές στην καρδιακή φαρμακολογία σε συνδυασμό με τις έγκαιρες επαναιμαθώσεις πραγματικά έχουν διαμορφώσει ένα εντελώς διαφορετικό περιβάλλον παθοφυσιολογίας, με αποτέλεσμα την αλλαγή της επιδημιολογίας του στεφανίου συνδρόμων. Έχουμε την μείωση των εκτεταμένων καταστροφικών εμφραγμάτων που θυμόμαστε με τον κύριο Κόκκινο παλαιόθεν, και την ανάδειξη νοσολογικών οντοτήτων, όπως τα σενάρια με την κατάληξη στο όνομα νόκα, μη αποφραγμένες αρτηρίες, μη νόκα, συνδυασμός με έμφραγμα, άι νόκα, συνδυασμός με ισχαιμία, αλφα νόκα, συνδυασμός με στιθάγχη. Είναι βεβλημένο παράλληλα να επισημάνουμε τη διαχρονική συνεισφορά του Τμήματος Επεμβατικής Καρδιολογίας, τόσο εκπαιδευτικά όσο και ερευνητικά. Ήδη από το 1994 μάλιστα θυμίζω με πρωτοπορίες στην ενδοστεφανία απεικόνηση, εκτίμηση στεφανίας φυσιολογίας ροής, διαχρονική συνεισφορά που καθοδηγήθηκε επιτελικά από τον καθηγητή Κόκκινο. Είναι χαρακτηριστικό ιστορικό παράδειγμα αυτής της εκπαιδευτικής συνεισφοράς η πριν από 15 έτη παρουσία του διακεκριμένου σήμερα Γκόραν Στάνκοβιτς σαν μετεκπαιδευόμενου τότε. Κατά συγκυρία, αγαθοί, η παρουσία του κυρίου Ιακώβου στη διεύθυνση, ο οποίος σημειωτέων διαμορφώθηκε επιστημονικά σε αυτό ακριβώς το περιβάλλον, έρχεται να επικυρώσει με αδιαμφισβήτητο τρόπο την διαχρονική αξιακή εγκυρότητα του Τμήματος Επεμβατικής Καρδιολογίας. Αγαπητέ κύριε Ιακώβου, παραφράζοντας τη ρίση του Έκτορα από την Ηλιάδα, «Ίσοι ονός άριστος αμήνεστε περιπάτρις», ρίση που είμαι βέβαιος ως διατελές σας στρατιωτικός έχετε ήδη εγκολποθεί, πλέον σας αντιστοιχεί το «αμήνεστε περί επεμβατικής καρδιολογίας» και δίστε ναρός θα προσέθετα. Σας ευχαριστώ.